and no financial interest involved. This is an important slide. So this is first described by Knapp in 1869 and modern concept and classification by Gass. And there are different studies selling prevalence from 3.3% to 1.7%, and bilateral in up to 11.1% cases. So Kelly and Wendell first time reported in Archives of Ophthalmology in 91 about the surgery, and successful closure of macular hole in 58% of cases they showed, and then recent closure rates are 95% about. So diagnosis initially it is by slit lamp microscopy, but it is replaced by OCT, and you can see there is a lamellar macular hole and the pseudo hole, which we can see in OCT nicely with the infus and the normal. The classification already described Dr. Rajesh Sahai, the correlation between the stages of macular hole, biomicroscopy originally described by Dr. Gass, and then the OCT recently came, and the international VMT classification, which you can get it. And then this is the working classification of the commonly used working classification for full thickness macular hole. The stage 2 is a small hole with a small or medium full thickness macular hole with vitreomacular traction. Stage 3 is a large hole with medium or large full thickness macular hole with vitreomacular traction. And stage 4 is full thickness macular hole with PVD, with small, medium or large full thickness macular hole without vitreomacular traction. And stages of macular hole, you can see that stage 1A is the impending macular hole, and the stage 1B is an occult. And there is one 3D structure. If you see, nowadays the OCT is so much telling, and which Dr. Gass, all the things he got with the slit lamp biomicroscopy, that is wonderful to think of now. And if we see the prognostic indicators of the macular hole surgeries, there are lots of prognostic indicators, like the size of macular hole diameter, that is the most important, they found it. And then the morphology and thickness of the foveal photoreceptor layers, and defective in interdigitation zone, external limiting membrane or ellipsoid zone. And then OCT parameters also came, like hole forming factor, macular hole index, traction hole index, and then also computerized aerial designing software came for the measurement of the macular hole volume. So there are plenty of indicators. And this is the practical things which we come for the surgeries, like dyes we use for the macular hole surgeries evolved over the years from thiamcinolone acetonide to indocyanine green to trypan blue and brilliant blue. And the adjuvants we use autologous serum platelet concentration, fibrinogen. You will find lots of papers published. The tissue adhesive, transforming growth factor beta 2, and the thrombin also. And the instruments we use, the ILM forceps, diamond duster scraper, Finis loop, peak. Even I say the PFCL is also one of the most important instruments. So we go to the inverse flap technique. That's all small cuts, and if you can see it, this is the here. The first video is not playing, but the second time you can see, we just peel the flaps all over, and we just trimming now, and with the cutter close so that the no extra flap is there, and making it smaller so that it fits nicely. And the tricky part is the fluid exchange, because if we are not careful during the last stage of the fluid exchange, those flaps may come into the extrusion cannula, and so slowly you do, and then the flap automatically goes inside the macular hole. And it is the very next step. You can see we put mostly SF6 here, and then you see this is a closed macular hole nicely, but you can see the tissues already inside. It's not organized well till now, but over the time it will be okay. There is one traumatic macular hole we can see where They're not playing. Or how to play them? Ah, you're just playing. Back, back, back. No, it came the next. And this is a traumatic macular hole surgeries. This is a full thickness macular hole you can see, and the papillomacular bundle you can see this is badly damaged already, and this is the surgical steps if you see. So what we did with the loops, we just coax and casuals whatever membrane ILM is possible, because this type of holes you may think that it is not possible to do anything, but we did a good job. In fact, you see, I think it is not possible to get the about 3/4 portion of the ILM you cannot peel. This is all scarred. So from the temporal, whatever is available, we just took it with the lip and put it into the hole, and we should be very careful because the all over the retina is thin now. And if you see, then we will did the fluid air exchange and put the gas, and if you see the result, and the hole is closed. Okay, and if you see the we use OCT, you see that nicely closed, whatever is that a type 2 closure maybe, but because the papillomacular bundle retina is missing completely all the layers, so it increased the vision by 2 lines. I think for this patient it is good. And then the temporal flap also we do sometimes, and that is also instead of pulling all the flaps from everywhere, we just take the temporal flaps and put them back and keep the papillomacular bundle area. In fact, if it fails somehow, we can use those flaps also. As that also is the same way, but it is much, you can say, safer, and the other procedures is the same. And the result is good only. And this is a RD with macular hole here. After the usual vitrectomy procedure and inducing the posterior vitreous detachment, there is one hole through which we drained and put PFCL, and then we immediately under PFCL we put the dye, and there is the advantage of BB dye below the PFCL is immediately you can start the peeling without waiting for the staining and other things, and that is in fact much easier than I should say the peeling in the attached retina maybe, and then the normal way you finish the OT. So this is the RD with macular hole surgery. You can see it's nicely closed, and the media is not so clear due to the silicone oil post-op. Thank you, and sorry for the